Good afternoon, everyone. Thank you for joining us this afternoon. I know in South Africa it's 4 p.m., and I'm sure in most parts of Africa, well, in Central African time, you are heading towards the afternoon and have had a long day and week. But I really appreciate you joining us today because we have a wonderful lineup of speakers. And today is our second clinical seminar to look at practical approaches to managing patients with common problems. Mental health problems. So today's seminar case presentation is focused on the improving sleep health. Teamwork makes dream work. So I think that's really important. And we have a fantastic team who's going to explain how they approach sleep problems. Bearing in mind that sleep disorders also affect not only physical health, but mental health. So really important for us to be inquiring about patients' sleep patterns, identifying problems and trying to address them early. Our first speaker for today is going to be Dr. Alison Bentley. She doesn't need much introduction. She has been a sleep expert in South Africa for many, many years. She is a general practitioner, but she has also been seeing patients with all types of sleep problems, both pediatric and adult. And she is also been working in this field for over 30 years. She has run one of her first private diagnostic sleep disorders laboratories in South Africa and is currently in a collaboration with Wits University in terms of running a sleep physiology lab together with Dial-A-Bed. So she's also involved in some research there and is the chairperson of the Sleep Society of South Africa. So I'm going to hand over to Dr. Bentley, who will then be followed by Dr. Michelle Baker, and I'll do the introduction just before she speaks. Thank you, everyone. Over to you, Dr. Bentley.
Thank you. So let's start this process. So we came up with a sorry, let me just make sure I'm hitting the right thing when I put something up there. Just share. So yes, so we're talking about teamwork in the management of insomnia specifically, and this is not to imply that specific patients should only go and see one person, but that insomnia is often not a simple diagnosis or a simple management problem, and that a bunch of people may be involved. But it also means that, for example, although I'm a doctor and Michelle is a psychologist and Helen is an OT, that we shouldn't learn techniques from those different specialties so that we can manage our patients better, because we know. So, for example, I, as a medical doctor, need to know how to do CBTI. I mustn't always just hand it over to somebody else. So it's really just to look at the components that could be involved in a patient with insomnia. So I'm going to start with a case presentation. So we've all worked on the same case presentation and how we would start managing this patient. So this is a 29-year-old female who presents with a 10-year history of insomnia. So started quite early at the age of 19. Initially slept a lot. So she said, all I did was sleep. And she was diagnosed with depression and anxiety. And she has been on psychiatric medications since then. They've alternated because she hasn't really found a good antidepressant that has worked well for her. But she currently is stable now, and her depression appears to be stable. She's on quite a bunch of meds. And this sleep problem that she had initially, where she slept a lot, suddenly changed to disrupted sleep, and now she couldn't sleep well. So she kind of had an insomnia problem. She then changed psychiatrist and was diagnosed, and anxiety was kind of added to the diagnosis. And she has tried lots of sleeping meds, but all alternative ones. She hasn't been on any benzodiazepines since then. So she's tried melatonin, and she's tried Seroquel, which is a dopamine antagonist, which has a sedating effect, an antihistamine sedating side effect, and that's why it's used. So she's tried those, and she hasn't really found something that works well for her to help her sleep. Currently, she falls asleep fairly easily, although sometimes there's some difficulty, but generally that's okay. But she feels as though she's just dozing, that she doesn't actually have a deep sleep, that she's kind of subsurfing. So she's just below the surface of sleep, but not actually what I would call thunk and die, that you just kind of really lights out and you sleep well. She wakes between 1 and 4 times per night for no real reason. And she's very aware that even if she wakes up once a night and she only wakes up for 5 minutes, that in the morning she's tired. And so she has a poor quality sleep. So that has been ongoing. The timing of her sleep, she goes to bed at 11:30 and switches off the light around midnight. And then she wakes up at 7. She needs to wake up at 7 for work, but she struggles to get up. And so she finally gets up later than that. So kind of at about 8 o'clock, she's able to get up. But if she doesn't need to get up early, she can just continue sleeping until midday. So she can put in almost 12 hours of sleep if she has the time to do so, which is in itself an abnormal kind of presentation. So my role as the medical doctor in this, and my kind of thing for this afternoon, is to never assume that there cannot be a biological disorder causing the insomnia. Just because she has anxiety and depression does not mean that the insomnia is guaranteed to be from that, or that those are interconnected at all. And so you have to ask about the biological sleep disorders, because if they are there, you have to treat them before you do anything else. Managing the insomnia isn't going to work, because you still have this biological thing interfering with sleep. So the questions we ask is, and the 2 big disorders that we look for are snoring and sleep apnea, and restless legs or periodic limb movement disorders. So there was no history of snoring or apnea. She's quite thin, she's quite young, there's no nasal obstruction, so there's no reason for her to have apnea whatsoever. She does have a bed partner says he's never heard her snore. But when we come to restless leg syndrome, she answers yes to all 4 of the diagnostic questions of restless leg. And that is an urge to move the legs, mainly at night or worse at night, worse at rest, and relieved by movement. So typically what would happen is the patient would be sitting still, and they would suddenly get, I have to move my legs, like they feel weird. Move their legs, and they kind of go, oh, that feels better. Stop moving their legs, and now they're back at rest, and about 25 seconds later, it comes back again. And this can be ongoing, and it just keeps going. In the very severe cases, it's really life-shattering, because you can't sit still and your legs feel terrible. It's very familial, and so we always ask about a family history. Her brother does have a sleep problem, but she doesn't know whether he has restless legs or not. No sleep studies have been done in her case in the 10 years that she's had this clear sleep disorder. So let's look a little bit more at restless leg syndrome. So there's a classical presentation, which is those 4 questions. Restless leg syndrome is diagnosed on history. Honestly, if you go through those 4 questions with patients who have insomnia, they will either look at you and go, no, I've never got that. Or they go, yeah, no, I've got that. And they will immediately say, and you say to them, how long have you had that for? And they'll go, oh, years and years and years. I thought it was because I wasn't exercising. I thought it was because I was standing on my feet all day. I thought it was this. I thought it was that. I thought it was the next thing. So they often put it down to a lifestyle change that's happened, or something that they're not doing as far as the lifestyle is concerned. But it's not that. And particularly in young people like this particular girl, she has had it for so long that she's not aware that it's abnormal, because it's just part of who she is. And so there's a normalizing of the restless legs. So the question is, what is the sensation about? The sensation is a moving. There is a moving. So children who have it are great, because they come up with all kinds of things. And so children will complain of Coca-Cola in my veins, that their muscles are pulling and stretching on their own, or their ants running inside their bones. The common theme is a moving. There's a moving happening inside the calves. Then there's circumstantial evidence. So you get this kind of sensation, strong family history. So mother has got it or dad has got it. Strong family history, 4 questions, and this kind of sensory thing, you've pretty much got a slam dunk, that's restless legs. But in some patients, it's harder to find the restless legs. And so I have circumstantial evidence that I use for that, and that is they sleep with a pillow between their legs. Now, if you have a back injury or back pain and you sleep with a pillow between your legs, that's great, that's fine. But if you kind of go, I don't know why, but I can't have my legs touching each other, they're like, oh, that's restless legs. Like there's a tension there that you can't sleep like that. Also, they will give a history that they sleep better on a painkiller, and that's a painkiller that has codeine in it. So in South Africa, that would be still pain, myprodol, gen pain, something like that, which has kind of usually paracetamol, codeine, and something else. They will sleep better on that than they will sleep on a sleeping tablet. So they'll give histories, for example, that they went in for a small op, they were given a painkiller, and they took that every night, and they slept beautifully. And when the painkiller stopped, their sleep came back. And that's because codeine is one of the treatment options that we have to treat restless legs. It's obviously not one that we want to continue, and it's obviously not one that we want to do long-term treatment with, but it is a really nice piece of evidence that we can use. The restless legs is aggravated by a couple of things. Antidepressants, all of them can aggravate restless legs. Caffeine, antipsychotics, because the mechanism of action, the original mechanism of restless legs is dopamine related or low dopamine. The antipsychotics further reduce the dopamine, and that can aggravate. But also things like anti-nausea tablets that you take for chemotherapy. Exercise can sometimes aggravate. Sugar can sometimes aggravate. There's a bunch of things that can aggravate restless legs, and patients often know what it is that aggravates. The important thing is that restless leg syndrome is one half of the disorder. The other half is periodic limb movements. And that's where once you fall asleep, so obviously the restless legs is going to make it difficult to fall asleep because you're trying to move your leg, get rid of the sensation, and fall asleep at the same time. And putting yourself under pressure, because when you get rid of the sensations, you've got about 30 seconds to fall asleep before it comes back. And that never works well when you're trying to fall asleep under pressure. But once you fall asleep, the legs are still restless, but they just look differently, and obviously you don't feel it. So the presentation is slightly different. So this is what we see in patients with restless legs on a sleep study. So I'm just going to walk you through it. So that's oronasal airflow. So all of that underneath there is all about breathing, and we can ignore all of it, but we do record and we look for apneas as well. Then routinely when we measure sleep, we measure left eye movement, right eye movement, between 2 and 6 EEG channels. And then the EMG is under the chin, just so that all the electrodes are here around the head. So we record all of those, and it's those 5 or so channels that we look at. And just by eye, and we kind of go, that is stage 2 sleep, that is stage 3 sleep, that is REM sleep. So that's the scoring channels that we look at. The muscle tone under the chin we use as an indication of muscle tone throughout the body. So we look for the drop in muscle tone that happens in REM, and we look for the increase that happens in wakefulness, for example. So we just watch that. And you can see it's fairly flat here. The next one below that, the TEMG, that's the tibialis anterior muscle, for those of you who remember your anatomy. Those of you who don't, it's the muscle on the front of the shin that pulls the toes up. So that muscle, and that's the muscle that we record. It's an EMG. It's an identical recording to the one that's happening under the chin, but you can see it looks very different. So these are the periodic limb movements, these bursts of electrical activity that are seen on the surface of the muscle. You can see the burst hitting the muscle. So these are the periodic limb movements. Now, there may not be movements at all. There may be just a very small twitch that happens, because this is not information that's coming from the brain as in move. It's not a movement. Where this is coming from is the base of the spinal cord, which is hyperactive because of a lack of dopamine. And the base of the spinal cord winds up an electrical charge. And when it gets to the threshold, those of you who remember second year action potentials, that you have a threshold and an all or none response. When it gets to that threshold, you get an action potential. So this is just a random electrical event that's going down into the muscles. But you can understand that every time these little events hit the muscles, there's a sense that the patient's going, oh, like, what was that? There was something happening in there. The movement that occurs can be just a tiny little twitch, or it can be a whole big movement. It really depends on the patient and other factors, such as have they taken a sleeping tablet, have they had alcohol, have they had, etc., etc. Now, the interesting thing is these were 2 separate disorders, restless leg syndrome and periodic limb movements. And then what people did was people who were having restless legs at the time that they were having it is asking them to sit still and record the legs, and you get this. So this is actually what's underlying both of these disorders and causing a sensation when you're awake. When you're not awake, when you're asleep, what it does is cause disruption in sleep. So the periodicity comes, you can see very clearly, there's 5 seconds at the bottom. You can see very clearly every 20 seconds there's a twitch, looks slightly different every time. And above each of those twitch is a less than a 1 second break in sleep. This is not enough to wake you up or for you to be aware that that's happened, but is enough to keep you just subsurfing. So you have a little brief wake up, you sleep for 20 seconds and you're awake, and you sleep for 20 seconds and you're awake, and you sleep. So the quality of sleep is terrible. It's very light sleep. You're not aware that you've been woken up at all, so the patient usually sleeps through the whole thing. If there are very few movements, actual movements, the bed partner wouldn't even be aware of it. But often they have restless sleep. So they'll say, like, my bed is a mess and all the sheets are kicked off in the bed. You kind of go, that's not normal to do that. Okay, so often that's the history. So importantly is, if I do get this kind of history in a patient who's got a long history of anxiety and depression as well, is that we have to treat the restless legs. It's a biological problem. It's not going away. And it is going to interfere with any other type of treatment that you try to do. And that includes sleeping tablets. So if you give this patient any kind of benzodiazepine, no matter what it is, it's likely to work for 2 or 3 days, but then it's going to stop working. Those leg movements are going to break through the sleeping tablet. So no matter what you try medically, medication-wise to treat these patients, it's not going to work, or it'll work for a little while and then stop working. If it's something like Seroquel or Dopacol, they're going to get much worse on it, so the insomnia is going to get worse. We do need to check the ferritin levels because there are some patients that respond to iron. And it may not make immediate sense, but we need iron in the brain to make tyrosine hydroxylase to make dopamine in the brain. So that's where the connection comes in with dopamine. So if we have low iron levels in the brain, then we make less dopamine. So we're running a bit low anyway. The nighttime thing is about another drop in dopamine that happens in everybody in preparation for sleep. And in people who do not have restless legs, we don't feel that drop in dopamine at all, except we get a little sleepy. But in patients with restless legs, because they're running low anyway, now they're running too low, and so they become symptomatic. So so obviously we check the iron. There are various things that people can do, and we only treat if there are symptoms. So you don't treat restless legs to stop anything in the future. There is nothing coming, but you treat for the symptoms, because and she's got significant symptoms. And it can present with both things. It can present with sleeping okay, but waking up feeling exhausted, and any kind of insomnia that you might like in between, so breaks in the sleep. So the recommended treatment at the moment are those for neuropathic pain, and that's always aimed at increased neuronal activity presenting as pain. We know that restless legs, the sensation runs in the pain pathway, so it is a form of pain. So we use gabapentin or pregabalin as first choice. And then if those don't work, or the patient has side effects, then we move on to pramipexole. And we use pramipexole for 15 years as first-line therapy. So it's not a second kind of tier drug. It was the first tier drug, but there are quite a bit of side effects with pramipexole. So you get some immediate side effects. So some patients get quite agitated when they take it. Other patients get compulsive behaviors. So I've had treated hundreds of patients. I've got 5. 2 of them had compulsive gambling, which started the day they just took their first tablet of pramipexole, and 3 of them had compulsive eating. So they need to come off the medication then. There's also some patients who get excessive daytime sleepiness. Then the big problem with pramipexole, so that's very small, those are very small side effects. The big problem is augmentation. And this is an effect that happens very specific to the dopaminergic. So whether it's Pixola or Ropinirole or whatever dopamine agonist it is. And that is that the whole thing switches around. And if you give the medication, it causes restless legs. So you end up with a bit of chasing your tail. So you give the medication, restless legs gets worse. So you increase the medication, so the restless legs gets worse, and you increase the medication. And you end up in a situation where no matter how much medication you take, you cannot get control of the restless legs. And that happens in quite a large percentage of patients. So we're talking between 40 and 60% of patients who are on pramipexole will get augmentation. So the sense is there's no much point in starting pramipexole if you know down the line you're going to have to get them off. And it's really hard to get them off, because the minute you reduce the pramipexole, the restless legs goes crazy. So it's quite a juggling act to kind of be able to reduce the Pixola as we add in the epileptin, the pregabalin or gabapentin. And so because of that, it's kind of gone to gabapentin as a first line choice. So I would always start this patient by treating the restless legs and see what's left. And once we know what's left, then we can manage that. And that may be then require behavioral therapy or some other therapy for insomnia. Okay, so that's my story. And I'm going to hand over to Michelle to give her story now.
Hi. Thank you, Dr. Bentley, for a very interesting case presentation. I'm not sure if anyone would like to ask any questions
No,
on
let's leave it till the end.
case
Let's
itself.
leave it till
You want
the
to
end.
leave it to the end?
Yeah,
Okay,
I think that's
perfect.
better.
Let me just introduce Michelle. So some of you may know her because I think she has spoken to us before, but Michelle Baker is also a clinical psychologist who's currently doing her PhD in sleep, and she has been quite supportive and helping us with developing some information on sleep for HMHI as well. And she also has done her master's in clinical technology and neurophysiology. She is an active participant in supervised training groups and has continued professional development. And she works in a private practice in Kloof, KwaZulu-Natal, South Africa currently. She is focusing on medical and neurological conditions affecting adolescents and adults in her practice, including ASD and ADHD, concussion, traumatic brain injury, epilepsy, pain and trauma, and functional neurological disorders. So all the complicated things in life. So we're going to hand over to Michelle to take us through the psychophysiological aspects of assessment and management of insomnia.
Thanks very much, Prof. Paruk, and good afternoon to you all. It's a bit of a shift in gear now into obviously a completely different approach to working with more behavioral treatments, where my job is to teach people how to manage their sleep disorder, without medication, and actually start relying on, the behavior and their habits that they have. It doesn't mean to say that they're not going to be staying on medication. So if I just follow on from this case, of Alison's, this is an absolutely ideal case for me to actually have. And Alison and I do in the real world work together extensively, because straight up, I know the diagnosis has been made. We've checked for comorbidities. And in fact, the sort of detailed history that I take normally would be, needing to go through evaluating all habits and practices, and also using some validated scales to make sure, that I've covered insomnia from the point of view of the fact that, how's it presenting? So if it's a specific psychophysiological insomnia, we've already got the diagnosis. I can then just proceed. But other than that, I would actually also just have to make sure that I'm also I'm treating using a behavioral approach, the condition in an appropriate manner. So some of the validated scales are very, very useful. I'm sure you've all used the GAD for anxiety, and you can use the PHQ-9 or even the Beck's Depression Inventory for depression. But we would also want to look at, the Epworth Sleepiness Scale, the Restless Legs Scale, and what's called the Stop Bang for obstructive sleep apnea, and then the Fatigue Severity Scale as well. But the main thing we do is actually then locate this problem into the 3P model. So we would look at what are the predisposing factors that are there any genetic or developmental contributions, what precipitated the problem. We can see in this particular patient, the problem was precipitated, quite some years ago. The thing that we often encounter, and we often talk about as sleep practitioners, is sometimes, insomnia just seems to start out the blue for no reason whatsoever. The sleep problem suddenly enters their lives, and they're really not managing their sleep very well. But then the perpetuating problems is, that question of, well, if something got it going, what is keeping this insomnia going? And it takes us through that trajectory of the acute phase of just not sleeping very well, And after about 3 weeks, there's now becoming an acute insomnia. Into that 3-month mark, we're now moving into a chronic problem. So, the sleep diary is what I'm going to focus on quite a bit here. And it sounds like a bit of a bizarre way to sort of work, but the sleep diary in what we call CBTI becomes very, very important, because what it does is gives us an idea of the habits of, what time did you go to bed? How long did you sleep for? Did you wake up? If you did, how many times? And this particular one that I've got on the screen at the moment is an app you can use. But the reality is not everybody's going to have, a cell phone and actually be able to use an app. You can actually use a handwritten diary as well to just ask them to fill it in for you. But the other thing is just asking the right questions. So the thing you're wanting to have, and just a little word on CBTI, so it's cognitive behavioral therapy for insomnia. It is actually globally the first line treatment for insomnia, and it is what doctors are supposed to be using as a starting point. And the reality is we just don't have the practitioners, certainly in South Africa, to actually cope with that. I was privileged enough to do my training in the USA. And, I've brought that back, and at the moment we are rolling it out with the South African Sleep Society. But it just does require that extra clinical knowledge, because whilst you can work with the cognitive behavioral aspects and you can kind of go, well, it's only got 2 arms to it, really. The 2 protocols for CBTI are to get people to schedule sleep, so that they're going to bed at the same time, waking up at the same time. You can kind of you can get them a prescription around that once you get the diary data. And then the other one is to introduce the concept of stimulus control. Now, this particular patient that Alison was working with, has experienced years of this really difficult sleep, of having very restless legs. And with it becomes what they call conditioned responses. So she develops habits to try and cope with her sleeping problems. And one of the first go-tos for most people is, if I haven't slept well, I need to catch up on my sleep. I need to go to sleep early. I need to make sure I've got opportunity to sleep. And CBTI turns that on its head. It said, don't do that. Don't extend sleep if you're not sleeping well. Shorten it. Don't sleep out of your phase, and understand, so as a practitioner, you're sort of asking your patient, you're getting that sleep story, and you're going sort of behind the lines, trying to understand what the little innuendos are and what their belief systems are around sleep. So we're looking for what we call the cognitive component, where they've developed these maladaptive strategies that they truly believe are going to work for sleep, and they're quite entrenched. So there is this constant, sort of heroing them, helping them along the way, and say, listen, you need to trust this. Across the world, science tells us that we can get insomnia right with this. So, trust me along the way. Let's get you sleeping at a certain time. Seems like you're an early bird. You've always gone to bed a bit earlier rather than later. You like to wake up early, or it seems like you're a bit of an average Joe, going to bed at about 10, waking up at about 6 a.m. Or actually you might be a slightly night owl, where you prefer to go to bed after 11, 12, like this case that Alison presented, and waking up around about 7. So it's really good to get them into their phase, understand what's called the chronotype, and then give them their schedule. And then the stimulus control with insomnia really means that if you are lying in bed trying to sleep, putting in effort and energy, and it's distressing you, and you're restless and tossing and turning, you're completely on the wrong track, and you need to get up and you need to get out of bed. And the premise around that really is to just get people moving, so that the mind is activated to something else. So they're not focusing on trying to sleep. They're not focusing on their distress and their annoyance and irritation. They're actually going, well, come on now, let me just get up. And, they'll just go off to what I call the cozy corner. They can just create a little space for themselves, where they go and they sit and read a book, or do a puzzle, or knit, or do something constructive, but not for very long. And when I say constructive, I don't mean in a stimulating way, but that's going to actually shift their mind from what they were worrying about to just being in the now, to just calming themselves down. So these are the three arms that we use. The protocols are stimulus control, which is the number one shifter. That is scientifically the one that we know has the most utility. And then the sleep scheduling, or what we call sleep restriction, it used to be called, people don't like that word. So we use scheduling. And then, sleep hygiene comes in to underpin everything. You all know about sleep hygiene. That's probably the one thing you have been taught about sleep. So with the treatment protocols for, CBTI, psychoeducation is, very, very important. And that's where, as psychologists, we have the advantage of being able to spend time with people and be able to foster, the sleep story, to be able to stay with the person, and also to be able to help them manage their own problem at the end of the day, understand how their brain works, that their brain is too alert, that what our job is to then almost reverse that, to calm them down. They have to work on what are the alerting factors, not focusing on trying to sleep. That's sleep's job. They need to leave that to the department that controls their breath and breathes, beats their heart and breathes their breath. So, and then also explaining a relationship, like with this patient of Alison's, understanding the relationship that's developed between them not sleeping and then the anxiety that's developed, and then why they've become depressed, and how to work with those different entities. And so sometimes you are using, pure cognitive behavioral approaches with that as well. But most of the time, you're really working into those sleep cognitions and helping them understand the kind of maladaptive strategies they've developed, to work with this. In the context where we're looking, with using stimulus control and sleep restriction, we've also got to remember that, not everybody sort of sleeps in a bedroom on their own, has the option of being able to get up and go and have a cozy corner. And, if you are sleeping in a room with other people, and even with your partner, or sharing a room with multiple people, you can't always get up, and go and, sort of get out of your bed and go and do something. So a lot of what we are teaching them are also the more adjunct therapies, where we work with things like relaxation training. Certainly breathing is the absolute key to everything. So, we know from so much research now how very powerful that particular deep belly breath, with a very long breath out, and also when it's that rotational breathing, how it can literally calm the sympathetic nervous system down. And when patients get the hang of it and they realize that it works, they can start locking into things like mindfulness, being in the here and now, fully present, non-judgmental of self and others, just being able to hang out and just wait for sleepy to come and to let go. And the minute they, sort of calm and relaxed and they can let go, then sleep comes back again. And then also, fostering, spiritual practices, helping them to understand, can just use mantras, prayers to just calm themselves, to distract themselves, or guided imagery or visualization. Having said this, and as I come towards the end of my presentation, we always have to work so carefully, with context and individuals and culture. So it is very, very important to be able to adjust and move between the spaces. We sometimes are kind of using a sleep diary when we're working under the tree, drawing pictures on the ground, where we're able to kind of just tell me how you sleep. What does it look like? Ask them to give us pictures and understanding of it, so that you adapt to a concept of a sleep diary. As a practitioner, you're really just trying to understand and start noticing the patterns. And you're also trying to notice where they give themselves extra opportunity, where they don't need it, or they're extending their sleep. And the encouragement always is to just try and get your sleep back, because we want a 24-hour cycle. We want you to be able to be awake during the day, building sleep load. And then at nighttime, you're going to have that within your biological rhythms that's really going to help your sleep. But with each disorder, with the complications of comorbidities, obviously there's adaptations along the way. So, in this particular case, there's a little extras we would give, like what would you do? And of course, exercise is always a first-line treatment for both anxiety and depression too. So I think as practitioners, we all punt that one. And with restless leg syndrome or PLMS, it would also help to alleviate symptoms. And then, if there are some, supplements, everybody maintains that magnesium works. And then being able to foster the compliance too is another part of our psycho education, helping them realize that the medication the doctors put them on is helping another condition. Sometimes we're also helping them to wean off, and then just educating them around the kind of things that might help. Thank you very much. And Helen, I'll hand over to you now.
Thank you, Michelle, for a very good summary. We're going to move on to Helen Roome, who is an occupational therapist in private practice. She has also been intricately involved with sleep disorders, but also her other big forte is pain, chronic pain. So we're really delighted to have you here today to tell us about how to handle sleep, because sleep and pain are often intertwined anyway. Helen's talk today is titled Treating the Problem and the Person, Occupational Therapy Interventions for Sleep Disorders. Over to you.
Thank you so much. Lovely to be with you all this afternoon. And today we're talking about how teamwork makes the dream work. And I really hope that there is an OT on your team wherever you are, because what OTs really try and do is to not just treat the problem, but to treat the person too. So the problem in the sense of the underlying condition, the symptoms, in this case, we're talking about specific sleep disorders, but also the person. How is that impacting on them, on their functioning, on their meaningful participation in life? So what am I saying? I'm saying that it's important today that we all remember that this is not just a female age 29 with a sleep disorder sitting in front of us. This might be, for example, Tundi, 29 years old with a sleep disorder and dysfunction. This is creating dysfunction for her. So I hope we can really emphasize that today. So treating the person is recognizing that they are a biopsychosocial, spiritual being. So there's going to be a variety of symptoms we need to look at. I think Alison touched on this, and Prof. Paruk has said it, that we're going to see physical symptoms. This lady might be having pain because the connection between sleep and pain is well established. Restless leg syndrome and periodic limb movements is something we see a lot in our persistent pain syndromes, fibromyalgia, those sort of things. We're going to have psychological symptoms, as Michelle covered, mood changes. And then we're going to have some other symptoms, and I'm going to touch on cognitive impact of sleep disorders. And all of these symptoms are going to be interfering with the functioning of this person who I'm calling Tundi. So as Alison said, they might not be sleepy in the daytime, but we are going to see an impact on functioning in all areas of this person's life. We're going to see what we might call bad behaviors in the daytime, which is because of the impact of sleep dysfunction on the executive functions. I'm going to get into that a little bit more just now. So we've got to think about this person in front of us who has a whole family around her back home who are also experiencing the impact of her sleep disorder and its consequences. Not just bad behaviors, but also dangerous behaviors. Because of the impact on executive functions, we might have problems of dangerous driving. We might have work-related situations that are quite dangerous. And then we're going to see the impact on other areas of functioning, like leisure, like the social life of the person. These are all focus areas for occupational therapists who look at the functioning of the person. More on the work side later. But what the impact on functioning means is that this person is now struggling to engage in the important life roles. She might be a partner, a parent, an employee. And these are really all the things that make life worth living. Now, if we were talking about a child, obviously this would be impacting on their role as a scholar, their ability to study, retain information, all of that. But we're talking about a 29-year-old. Then just thinking about the interaction with their context, Michelle touched on the sort of social cultural aspects. Again, this is not a single person sitting in front of us. This is a person connected to another social circle, connected to a culture and a community, and the ripple effects go out. So my point here is that it is actually the suffering, in other words, the impact of symptoms on independent and meaningful engagement in life, that actually brings people to seek healthcare, not symptoms alone. Many people out there are living with symptoms. They may not even know it's because of their sleep, but only those who are suffering from them seek help. And so we can't just address the symptoms of a problem. We need to address the suffering of a person. And that's what OT does. So in terms of Tundi today, Michelle has covered some of the psychological aspects that come into play. And although as an occupational therapist, we would focus holistically on all of these, what I want to just dive a little bit more into in my presentation is some of those cognitive symptoms that come from sleep disorders, and then how they interfere specifically with work and with the person's role as an employee. So firstly, in treating the problem of the sleep disorder, we might teach some of the very same adjunct therapies as Michelle has covered already. We might reinforce those already taught by other practitioners. I think where OTs really come into play is that we are able to sometimes contextualize and routinize the strategies that are taught by other practitioners. So for all of us, it's not just important to know what will help this person, medication and non-medication strategies, but how are they going to implement them? Because they are unique individuals with unique social cultural factors at play and so on. So OTs can help with the how part of this. But we can also add a few extra things here. Sensory regulation strategies might be helpful for helping prepare someone to go to bed, to help with calming some of the nerve signals that are going on behind this disorder. And then talking about this particular case of her strategy of sort of trying to sleep longer in the daytime, as Alison said, that is not a functional way to live. You cannot have someone taking up half their daytime hours sleeping. They can't then participate in society. So teaching other more appropriate active coping strategies instead. Now that's treating the problem of the sleep disorder and maybe some angles that an OT might take. What about sleep, treating the cognitive dysfunctional problem here? So firstly, I think we must consider that this is 10 years down the line. You can imagine that there would be not only functional, but even structural changes in the brain. The good news is that neuroplasticity means we can reverse changes to some extent. So we're aware that it's been a long time, there are changes, and yet we know they can be reversed to some extent. And as I said earlier, the main changes we might see in Tundi, this person, would be in her prefrontal cortex. And this is an area of the brain responsible for what we call executive functions. So it's all about her ability to manage her behavior. And so loss of that ability means all the bad behaviors. So she might be very emotionally labile. She might be very irritable. She's increasingly impulsive. Her judgment might be impaired. All of that is part of self-regulation. That could have such an effect on her relationships at work, at home, and so on. But there are also some other functions that the prefrontal cortex is responsible for, like attention, planning, decision-making, problem-solving, really high-order key functions. So what we might do from an occupational therapy perspective is, while the sleep problem is being addressed and maybe improving, we might need to teach Tundi to compensate for the cognitive dysfunction she has in these areas. And then when and if she's ready, consider cognitive retraining for some of those functions. Why do we do this? Again, it's because we want to get Thandi back to functioning as independently as possible in her life roles again. So speaking of life roles, let's talk specifically now about the role she might have as an employee. Again, what struck me about this case was the fact that, yes, this is 10 years now, from when she was 19 to 29. What has her work life even been like? Is she still working at this point? How productively is she working? We don't know. But let's assume she is still working. What we're going to see is that her sleep problem has led to cognitive dysfunction in, as I said, predominantly the prefrontal cortex with these executive functions. So we're likely to see this come out in her work performance in the form of reduced productivity, increased errors, slowed reaction time. All of this could then be impacting on the safety in the workplace around her. So as OTs, as practitioners, we would want to know what kind of work does she do? And does it involve things like driving, responsibility for other people, operating machinery, high-order decision-making that impacts on economics, all sorts of things like that. And we might need to engage the employer and actually talk about realignment into an alternative position, or at the very least, looking at what we call reasonable accommodations that might be needed while she is recovering to some extent. And in OT, we use a model called the PEO model, where we look at the person, what can we change for her in the way she's doing her work, the environment around her, how she is set up, and then her actual occupation. So in covering these aspects, I'm just making us aware that we want to treat the problem of the sleep disorder and the person suffering from it and restore them to that independent engagement in life roles as far as possible. So thank you so much, and we can open up for some questions to any one of us.
Thank you, Helen. Very concise and comprehensive summary. I will open the floor to discussion. I don't see anything in the chat box, but you're welcome to unmute and let us know if you have any comments, suggestions, questions. I really liked the approach you took, Helen, in terms of thinking of it as an individual rather than a disorder, because I think that's so important. And I think the other big area for me is always that people have a lot of counter-transference about people who have sleep problems because, you know, they worried that they're not going to get them better, and so you're already on the defensive, and it just impacts on your therapeutic relationship and maybe listening to the patient properly. Sorry, are there questions? Or I can't.
So I can add just a little bit on that topic. I think that we often find that the patients with insomnia get obsessed about the numbers at night. Like they obsess about 7 hours and this much and no waking and things like that. And it's often quite hard to turn them around and go, I don't care what the numbers look like at night. How are you during the day? Like that's what we need to focus on. We need to focus on that you are good and you're functioning well during the day, no matter what it looks like at night. So to kind of shift it away from obsessing about things they think they can control, how much time they sleep, you know, when this kind of thing happens. So I'll always say to patients, I don't care what's happening at night. How are you during the day? Where are we at?
Yes, I really like that, Alison, because I think to add to what you said there, I think we can spend a lot of time trying to measure sleep instead of understanding it. So just understanding actually what is it doing, yeah.
To answer Prof. Yeah, about the CBTI app. So it is available in South Africa. It's actually designed by Stanford University. You can download it. It's a free app, which is, you know, really cool. So I use it for all my patients that, you know, have phones. Is it adaptable culturally? No, not yet. And maybe that's a bit of a challenge for us to actually develop an app that is appropriate and, you know, adaptable to different languages. But it's very user friendly. It's incredibly smooth and easy to use. Just answer like 5 questions when you wake up and press save, and then by the time you go back to your practitioner, you've actually got a week's worth of sleep data. The other thing that's really nice about it is it's a teaching tool as well. So it actually has quite a lot of sleep hygiene and discussions. What's quite funny is if your sleep is really bad, after about 3 days, there's like warning signs that start flashing saying you must see a sleep practitioner, your sleep is really shocking. So but it does give you it gives you a sleep prescription if it feels your sleep is not too bad. So it's a very useful one and is available. I would imagine it's available across Africa, where there's Wi-Fi.
Thank you, Michelle. So a question from Dr. Mafuze. Does a leg amputee experience restless leg syndrome, or does it shift to the other limb? Or does that become more like phantom in nature?
Yeah. So I honestly don't know the answer to this because I have never had a patient who has had restless legs and then had an amputation. So I honestly can't tell you that I have any important information. I mean, what's certainly true is you do get more restless legs if you have peripheral neuropathy, for example, something like diabetes. So you are more likely to have it. And so it's potentially is there. It can shift to other limbs. I mean, I do remember we did a clinical trial on ropinirole when it first came out many decades ago now. And I had a patient, and the kind of protocol was they come back after a week. If it hasn't improved, you increase the dose. And if it hasn't improved, you increase the dose. Well, it started in his feet, and as we increased the dose, it went up the body. So it just moved to his thighs, and then it moved to his abdomen, and then it moved to his hands, and then it moved to his shoulder, and then fortunately apparently shot out the top of his head because then he was fine. But no, you can get, it should be called restless limbs syndrome, not restless legs. You can get restless arms. I have a patient who in fact has restless bladder. And it's something that I read up about, and I've never heard of this before, and then I got a patient with it. So he goes to the toilet 8 times a night during sleep. There's very little urine there, and he has restless legs as well. And when we put him on gabapentin to treat the restless legs, then he stopped going to the toilet at night. So he had restless bladder. Yeah, so it can be anywhere.
Thanks. There's another question. Helen, is your hand still up? No. Okay. African roots in our region that might affect sleep, like cut in East Africa.
African roots like cut.
I'm just
you mean as in if you take it, is it take as a treatment? Is that what you're thinking?
Is it a treatment?
It could be taken as a treatment. It could be given to someone to take. It could be part of your diet.
I don't know.
Maybe we can even open the floor
what I was going to say about
participants who may have had some exposures to different diets.
What I was, there was a comment about, is the CBTI coach culturally adapted? And the difficulty with that is we don't know how many Africans sleep. We just don't know what the cultures are around sleep to do that adaptation. So the push really is to get the research done, because we could say, is it locally adapted? Well, we don't know what to adapt for because we don't know how our patients are sleeping. I think it is aimed, all of the CBTI kind of are aimed at first world kind of socioeconomic level. So I think the socioeconomic level is more important than the culture. And as Michelle said, it's a very different scenario trying to do CBTI where you have everyone has their own bedroom and you can have control over your environment versus a more lower socioeconomic class where you have 5 people sleeping in one bed in one room. Like, how do you do CBTI in that? So that we don't have because we don't have the data to know how to adapt it. So that's my push. Do the research, people. Come on.
Yep. Well, I'm busy with that. And the interesting thing with the
focus groups, I know. I'm just saying everybody. It shouldn't just be you. Everybody. I'm just saying everybody.
But they don't talk about sleep. It's very hard to get them to focus on sleep, And then, of course, we also are going to look at the more, African traditional approaches. So, I may have an answer to that, with the use of, what are the actual remedies that are used, that traditionally work. I mean, in the sort of traditional approaches with, you know, natural medicine, you know, the valerian and chamomile, etc., you know, and cannabis is the new kid on the block, but or maybe not the new kid, but it certainly seems to be widely accepted everywhere. But there probably are, you know, some very, you know, specific things to South Africa that we'll find, and it'll be exciting through the process to pick that up, because we just don't know, and they don't talk about sleep or actually use the word insomnia per se to describe it.
Well, not only that, we don't even know what words are available in other languages for sleep. So we don't. So what is a nap called? What is a nap? What is it called? What is the word for that? We have nap and dozy and falling asleep and quality sleep. And we have all of these English words for sleep, and we don't know what other languages, what the words they have. If you don't have the words to express what's happening, you can't express, you can't complain of something. So we don't even know that part of it. I mean, that's a lovely PhD, is to do the different languages and how they see sleep, you know, in and good and bad sleep, how they see it and how they describe it in their language. Oh, and I can tell you, Dacha works beautifully for restless legs, by the way. I'm not recommending it as a treatment.
Yeah.
Thank you. Thank you, everyone. Any other comments from the participants, audience? I think that brings us to the hour. Thank you, everyone, for really keeping to time, keeping your presentations very concise, and the recordings will be available to share with on our website. So hopefully people will, when they get a chance, connect again and listen to you and be able to maybe take some of this back into their practices. But I think also what today shows is that we still know very little about sleep in our own setting, and there's a need for a lot more work, both at the level of just understanding what's going on in the scope of the problem, but also possibly in terms of what best interventions would suit our settings. So thank you, everyone, for joining. Really appreciate it. Thank you to STAY and Senate for organizing this. And we will be having our next meeting, I think, in the next quarter. Thank you, everybody. Bye.
Bye.
Thank you to the speakers as well. Bye.